Hello, everyone, and welcome to our training series on a topic that's at the heart of everything we do, pain management in the pediatric population. I'm your host, Dr. Gerdes. Over the next few minutes, we're going to dive into the art and science of assessing and diagnosing pain in our youngest patients, from tiny neonates to talkative teens. Our goal is to equip you with the confidence and tools to make a real difference at the bedside. Let's get started. So, what's our roadmap for this session? By the end, you'll be able to clearly articulate why routine pain assessment is so non-negotiable in pediatrics. We'll identify those tricky barriers that can get in our way, and you'll become a pro at selecting the right validated pain tool for the right child, because what works for a 10-year-old won't work for a 10-month-old. Finally, we'll see how applying these scales helps us accurately diagnose, monitor, and fine-tune our treatment plans. Think of this as your practical toolkit for becoming a pain management champion. It's a tough question, but one we have to ask. Why is pediatric pain still so often undertreated? It's not for lack of caring. It's often due to these persistent myths and systemic hurdles that we've all encountered. We're talking about the outdated and frankly incorrect belief that infants don't feel pain like adults do. There's also the very real provider fear of opioid side effects, which can lead to underdosing. Sometimes pain assessment just isn't integrated as that fifth vital sign as rigorously as it should be. And finally, we occasionally face cultural or parental beliefs that can complicate our approach. Acknowledging these barriers is the first step to dismantling them. Pain is a constant character in our daily work. Just think about your last shift. You likely saw pain from an acute illness, like the misery of an ear infection or the sharp pain of appendicitis. Then there's procedural pain, that ouch from an IV start, a lumbar puncture, or even a simple dressing change. And of course, there's the significant post-operative pain and the distress from traumatic injuries like fractures. We also see acute on chronic pain, like a vaso-occlusive crisis in a child with sickle cell. Recognizing these common sources helps us be proactive, not just reactive. So, what are our golden rules? First and foremost, adopt a proactive approach. Don't chase pain, anticipate it, and treat it early. Second, assess systematically and regularly with the right tools. Third, employ a multimodal strategy. Think of it as a 1-2 punch against pain, combining medications with non-pharmacologic interventions. And this is a big one. Involve parents and caregivers. They are our experts on their child and are essential partners. Lastly, always prioritize the least noxious route. If a child can take something orally, let's spare them the needle. These principles are the bedrock of compassionate, effective care. Why do we need a formal assessment? Because they look like they're in pain just doesn't cut it for safe and effective care. Systematic assessment is the cornerstone. It's what allows us to establish an accurate diagnosis, to guide our choice of analgesics, and, most importantly, to know if what we're doing is actually working. It improves communication across the team, the child, and the family. And let's not forget, it fulfills our clinical standard of care. When we truly treat pain as the fifth vital sign, we give it the attention and respect it deserves. All right, let's open up our toolbox.
Pain assessment tools generally fall into three categories. The gold standard is self-report, where a child who is able tells us what's wrong. Think of the FACES scale or a numeric rating scale. For our pre-verbal or nonverbal kids, we rely on behavioral or observational scales, like the FLAC. Here, we become detectives, scoring behaviors like facial expressions and leg movements. And third, we have physiological indicators, things like heart rate or blood pressure. But a word of caution, these are just supplemental cues. A high heart rate could be pain, but it could also be fear or fever. They are part of the puzzle, not the whole picture. Assessing our tiniest patients in the NICU and on the infant ward presents a unique challenge. They can't tell us what's wrong, so we are completely reliant on interpreting their behavioral and physiological cues. It's our job to be their voice. To do this, we use specialized observational tools like the NIPS for neonates, the PIP for premature infants, or the CRIES scale. For our little ones who are sedated and ventilated, the Comfort B scale is our go-to. These tools give structure to our observations and help us make informed decisions. Let's take a closer look at the NIPS scale. This is a fantastic, quick tool for our term and preterm neonates. It's a 7-point scale that scores 6 key behaviors: their facial expression, the quality of their cry, their breathing patterns, arm and leg movements, and their state of arousal. You score each category, and a total score greater than 3 is our trigger. It tells us this baby is likely in significant pain and needs an intervention. It's simple, validated, and incredibly valuable. Now for a tool many of us use every day, the FLAC scale. This is your go-to for children from about 2 months to 7 years, or for any older child who is nonverbal. FLAC is an acronym for the 5 things you observe: face, legs, activity, cry, and consolability. You score each category from 0 to 2, giving you a total score out of 10. A 0 means a happy camper, while a 10 indicates severe pain. It's a lifesaver when you have a 3-year-old who's too overwhelmed to point at a face chart but is clearly showing you their distress through their body language. Ah, the Wong-Baker Faces Scale. A classic, and for good reason. This is perfect for kids aged 3 and up. The magic here is in the instructions. You explain that each face is for a person who feels happy because they have no pain, or sad because they have some or a lot of pain. Then you ask the child to choose the face that best shows how they are feeling. It's not just point to the face that shows you're ouchy. By using the recommended script, you anchor the faces to the concept of pain. It's simple, intuitive, and gives kids a real sense of control in a scary environment. Once a child is around 8 years old and can grasp the concept of ranking numbers, we can introduce the Numeric Rating Scale, or NRS. This is the 0 to 10 scale we're all familiar with. The key is explaining the anchors clearly. 0 means no pain at all, and 10 is the worst pain you can possibly imagine. This tool is great because it gives us a clear number to track over time, but it does require that abstract thinking. So if a child is struggling with it, don't hesitate to go back to the FACES scale. The best tool is the one the child understands.
Of course, one size does not fit all. We must adapt our assessment for specific populations. For children with cognitive impairments, the standard FLAC might not work. That's where the revised FLAC, or RFLAC, comes in, and where input from parents is absolutely vital. They know their child's unique pain behaviors. For our intubated or paralyzed patients, we rely on tools like the Comfort B scale that don't depend on motor responses. And never underestimate the importance of using professional interpreters and translated scales for non-English speakers. Finally, be mindful of cultural differences. The way pain is expressed or suppressed can vary widely. A quiet child isn't necessarily a pain-free child. A pain score is just the headline. We need the full story. This is where we put on our detective hats and use the PQRST mnemonic, especially with kids who can talk to us. P, what provokes it or makes it better? Q, what's the quality? Is it sharp, dull, burning? R, where is the pain and does it radiate? S is for severity, that's our pain score, and T is for timing. When did it start and what have you tried for it? Going through these questions gives us a rich clinical picture that a single number can't capture. It turns a pain of 7 into a treatable diagnosis. Assessment is a process, not a one-and-done event. The frequency depends on the clinical situation. Immediately after surgery or while a child is on a PCA, you'll be in high-intensity mode, assessing every 15 to 60 minutes. For a more stable patient on oral meds, routine checks every 4 hours and as needed might be appropriate. But here is the most important rule. Always reassess pain 30 to 60 minutes after any intervention. It's the only way to know if our treatment was effective. It closes the loop on care. You know the saying, if it isn't documented, it wasn't done. And in pain management, that's critically true. Be specific. Don't just write child in pain. Write FLAC score, 6 out of 10. Crucially, document the score before and after you give an analgesic. Note the child's response. Are they calmer? Did they fall asleep? Include relevant quotes from the child or parent. Consistent, clear documentation is what allows us and our colleagues on the next shift to track trends and provide continuous, high-quality pain relief. All right, let's bring it all home. Remember, pain is the fifth vital sign. Its assessment is foundational to our practice.
Your choice of tool must be tailored to the child's developmental stage. A holistic assessment is always best, combining self-report when you can get it with behavioral observation and priceless input from caregivers. Document consistently and reassess frequently, especially after you've given something for pain. And finally, the most important takeaway of all, the most reliable indicator of pain is the patient's report. If a child tells you they are in pain, believe them. Thank you.
For those who wish to dive deeper, here are some of the key references and guidelines that inform best practices in pediatric pain management. Thank you again for your time and attention.